breast cancer occurring during pregnancy. Yes. First of all, it's an extraordinarily ethically challenging, physically challenging, and emotionally challenging event for the woman, and maybe for her family and friends. It's emotionally challenging because, first of all, they've been told that they have a disease that could be fatal, breast cancer. It's still, many people think of it that way, even though we may not. And at the same time, they have a baby. And they are wondering, can I have my baby? What will happen if I have treatment? And will I be alive to see my baby? So the first challenge is to try to negotiate for that woman those issues. We need to know about the disease. We need to know about the patient. We need to know the expectations for the baby. So it's not a single doctor decision about what to do. It involves a team. The team usually is maternal fetal medicine, often is radiation and surgical oncology, often is imaging physicians to help us gather enough information about the disease and its potential impact. So it's a very challenging thing. Then the ethical part is, how do we assure ourselves that we're doing right? So this requires a little bit of a formal approach, a little systematic approach to assessing right and wrong. And we always talk about measuring risks, burdens, and harms versus benefits for treatment, right? Disease, treatment. But here you've got a third party who happens to be completely innocent and have no voice. Mom is the voice. So in the U.S., mom speaks for the baby. And I've had people decide, I won't take any treatment. And I've had others decide, I want every treatment. So if we make a decision that we're going to treat the cancer during pregnancy, the next question is, what are our options? What do we have to treat? And generally speaking, the options aren't any different for the pregnant person than for the non-pregnant woman. So surgery is an option. Well, what type of surgery? Mastectomy has been the standard. We have shown that you can do breast-conserving surgery, depending on the circumstances. The outcomes are good. By good, I mean they're the same. Systemic therapy. Well, in most of the pregnant women, the tumors are hormone receptor negative. So trying to manipulate hormones is not a good idea. It's also not a good idea if the woman wants to maintain the pregnancy, because hormones are essential to delivering a baby. So that leaves us with chemotherapy or biologic therapy. Chemotherapy with cytotoxic drugs, or biologic therapy with trastuzumab, also known as Herceptin. There we have to assess the biology of the cancer. So we talk with the woman about what's the risk of a biopsy. Well, if you do a needle biopsy, very low risk. You get information about type of cancer, hormone receptors, HER2 status, and you can make a reasonable decision and reasonable estimate of the risk of the cancer. After all of that, then it's time to see the maternal fetal medicine specialist and assess, where's the baby? What part of gestation are we? First trimester, first 8 weeks, 16 weeks. When do we expect we would deliver this baby if everything went perfectly well? You know, we'd like to get to 40 weeks. 35 weeks is safe. Getting under that, we're starting to get unsafe. So we have a maternal fetal medicine specialist see them and estimate age of the baby, health of the baby, growth of the baby, and we have a direct communication. Once we know that, the mother knows that, and we can talk then, what would be the impact of treating the cancer for you? First person to take care of is you. Second person is your baby. So I separate those two discussions usually, say this is what would be likely to happen for you. The side effects of drugs, the outcome of the cancer, what we would do at what time frame and so on. And then we say, well, this is what our experience has been in treating women who are pregnant with these agents, with these drugs. And all cytotoxic drugs work by killing cells that are growing. And there's nothing growing more rapidly in your body than your fetus. So the question is, how much are they going to get? And we have treated a number of people after the first trimester, which is the period when the organs are forming. You're making your fingers and your toes, your liver and your nose. After that, it appears to be safe. Appears to be safe in the short term, at least. We only have 20 years follow-up. So we don't know what's going to happen at age 60, but we know up to 20 years for some of our folks. And then a decision has to be made by the patient, whoever else is advising them and supporting them, and the physician. So there are a number of possibilities. If the woman says to me, I don't want treatment for my cancer, I just want to go and deliver my baby, I will probably talk with her very sternly about why I think that might not be a good idea for her, because it increases her risk of dying of the cancer and leaving the baby without her mom. And we would go back and forth in that discussion, trying to reach what is right for her. The second thing that some people have been told before they even come to see me is you must terminate the pregnancy. So we discuss, what does that mean? It doesn't help the cancer. As far as we can tell, it has absolutely no impact on cancer. But certainly there's no baby. So you don't have to see me. You can see anybody. You don't have to worry about it. But if you want to have the baby, then we need to be very judicious. So termination, most people don't come to see the cancer doctor with the expectation of terminating the pregnancy. They expect to try to maintain. That's been our experience, at least. And then the third decision is, okay, let's go and treat. How do we do it? What's the next step? And all of the things attendant to that are the same as for the non-pregnant patient. You assess liver function, kidney function, blood counts, decide on what the drugs are going to be, how you're going to give them, when you're going to give them. But an important added component of that is every 4 weeks, you see the person. Every 4 weeks, maternal fetal medicine sees the person and assesses the baby. And we know before we begin the next program where the baby is, what the growth and development have been, how mom is feeling. So you try to make that communication step an essential, just as essential as measuring the blood count, and probably more important for the baby. And then you try to plan out, when is delivery going to occur? Because usually you can predict fairly accurately it's going to be at 40 weeks. Now, we've been able to get most of our folks to 38 weeks. Some a little earlier, some a little later. One woman went 42 weeks. She was very unhappy about that, you know. But that's the approach that we have taken. Many of our mothers deliver at a time when they have no hair. And they're very distressed because they have no hair, and totally amazed because their baby has hair. And they can't figure that out. We presume that not as much drug got to the baby as to mom because they have hair. So that would be for us an encouraging sign. There are all kinds of correlates with that. They get a lot of advice. The web is a wonderful thing, except you hear all the horror stories on the web and not necessarily the happy things. So the pregnant woman with breast cancer is a challenge, clinically, ethically, morally, logistically, every way you can think of.